days is the ideal window of opportunity to treat these patients.
It's reassuring to see how the lamella is so mobile up here, what's reverting, right? Because you're going to expect the true lumen to re-expand nicely.
Okay, Andrej, are you using anything specific to position the graft now in terms of US pacing or?
Yes, absolutely. So we think this is very important to lower the blood pressure in a very controlled way during the implantation, not to have the blood stream push down your graft. This is a captiva with best blood, so the proximal part is hold together. This already diminishes the problem of windsock effect, but clearly not completely. So we definitely always use right ventricular overdrive, something like 180, maybe 200 beats per minute, and we checked this already, and we can really lower this blood pressure here very nicely. So we are ready here also to give an angio over the left groin with a pigtail catheter, and this could be maybe a good position here. As you see on the camera, maybe the C-arm is nearly 90 degrees here. This, of course, makes it a little bit problematic to have X-ray through the whole body in this session. So a little, let's say 80%, this is 60%. You see maybe on the CT that the arch is nearly vertically in the thorax. So that means that we also have to move the C-arm nearly horizontal to have a 90-degree X-ray on the aortic arch. Okay, I think we are ready here to give a shot. Maybe, shall we do this with overdrive or not? Definitely with apnoe. Is that convenient? We can do this with overdrive as well.
It's a nice idea to do rapid pacing during the delivery of contrast because you have more time. It fills up the aorta much better. You get better images.
Yes. And you need less contrast, maybe. Okay, dann hätten wir bitte einmal Apnoe. Und overdrive. You can see maybe on the monitor now with the camera that now the blood pressure is something like 60, and that would be a little too much distal. Overdrive out und weiter atmen. And now he's back to his normal blood pressure. Yeah, so the 8 markers are at the left common carotid. That's too far. Our plan is to maybe half overstand the left subclavian artery, because the dissection is around the subclavian artery, starts there. I might open the graft maybe a centimeter proximal to subclavian artery. Once one segment is open, I might pull it to the right position. But then it might be difficult if I'm too low to push it up again. What do you think? That's also your technique on the panel, or let's do this one?
I think
just not to do them.
I think we all agree with it. So go ahead.
Well, what could be discussed at this point? Would be monitoring of the procedure with transesophageal echocardiography, which shows you nicely during the procedure how the false lumen kind of shrinks and how the flow stops in the false lumen. You can see that while delivering a stent graft. So we have an attitude to use that almost every time.
Okay. So now we need apnoe again. Yeah. Just a moment. So I pull this the ring. You see the marker of the delivery catheter going to the 8. Now we should start taking apnoe. Yes. Apnoe and overdrive. Overdrive on. Okay. This is, I think, a good position. What do you think? You can do another. Weiter, overdrive, alles so lassen. I think this is a very good position. Overdrive out und weiteratmen. So you can see the 8 markers are nearly on one line, so the C-arm ambulation is actually quite correct. Out, over, ja, alles okay, weiteratmen, ja. Ja. be quite covered with left subclavian. But we checked also the vertebral arteries beforehand. So clearly we have a strong vertebra on the right side. We have a good connection from both vertebral arteries at the pulmonary artery. So if you oversize here in this case, the subclavian artery, no problem.
The challenge is that in many cases the dissection really extends down to the origin of the left subclavian, or at least there's a lot of vulnerable tissue in that area. So it's always our approach to really go as close as possible to the left subclavian.
Actually, in most cases, we find that we cover the left subclavian for type B stimulus.
Actually, in many cases, you are forced to go at really that high that you have to cover. You're right.
I think at this point it would be worthwhile spending a minute on this issue of coverage of the left subclavian artery. In elective cases like this, I mean, you have the time to check for the interstitial connection to the posterior circulation, which is essential if you overstand the left subclavian. If you have proof that all four feeding vessels are connected to the circle of Willis, it's fine. If you have a right predominance or right dominance of the vertebral artery, also it seems in most cases to be fine to overstand the left. But in very few cases, I think you can run into a pica anatomy, which could be detrimental. So in elective cases, I would argue for either doing an MR angiogram prior to stenting, or to overstand the left subclavian, or to just bypass it in the same setting. What do you think?
Yeah, that will be our approach. So we always check the posterior circulation, and either angiographically or with the MR angiogram. And you're right, I think we have a very low threshold. If you are in doubt that the left side seems to be the dominant side, or there's not absolutely clear whether there is a good communication, we would transition the left subclavian or bypass it. But here, Andrej, actually your graph position is actually very good. So half the subclavian is